Hello and welcome to Talking About Tumors with Ryan and Ryan. This is Ryan Holstead.
And this is Ryan Quinn.
And today we're going to discuss some recent developments in early hormone-positive breast cancer, specifically going over recurrence risk scores, as well as the role of adjuvant CDK4/6 inhibitors. We're going to do our best to stick to an every 2-week release for our episodes. Been a little bit trickier over the last few weeks, but hopefully as we adjust to the new pace of life, we'll get back on track.
Also, to those of you who are internal medicine residents, good luck with the match. I know it's coming up soon, stressful time, but very exciting.
Okay, so going back a little bit, as we had discussed, the general approach to hormone-positive breast cancer in the adjuvant setting, which historically has been utilizing adjuvant chemotherapy for node-positive breast cancer, followed by an anti-estrogen agent, whether that's a SERM such as tamoxifen or an AI such as anastrozole, letrozole, or exemestane. For node-negative breast cancers, traditionally those without any high-risk features, such as T1As, T1Bs, or T1Cs with well-differentiated features, we would often omit chemotherapy as the benefit is likely small. That being said, there are known to be a number of patients who are node-negative who fall into this sort of gray zone in which the benefit is small, although we do know that there are certain patients who are destined to recur. And over the last 10 to 20 years, there's been a number of tools developed with the goal of increasing our estimates of risk recurrence to better select the patients who benefit from chemotherapy.
Yeah, exactly. We really want to figure out who benefits most because, as we've said, chemotherapy can have some long-term side effects such as neuropathy, cardiotoxicity, even some blood disorders like MDS, AML. So we want to make sure that we're picking the patients that are most appropriate. There used to be, and still is, used some clinical risk calculators that are online that you can type in clinical risk factors, but now we're really leaning more towards a biomarker-driven approach with some of these new assays that we'll be speaking about.
Probably the best studied and most commonly used is the Oncotype, but there's also other scores such as the PAM50 score, MammaPrint, EndoPredict, the Breast Cancer Index. In general, these are next-generation sequencing tests in which we take a portion of the biopsy and sequence it for a number of genes that are known to correlate with increased risk. So beyond just kind of our generic high-grade, medium-grade, low-grade, or Ki-67 counts, these are taking into additional genes and depending on the score, it may use anywhere from 25 to over 70 genes to help incorporate a risk. All of these scores have had some area of validation. Primarily, these were done as retrospective validation on prospective trials. So taking the previous randomized controlled trial, digging up all those banked biopsy tumors, and then running these tests on these biopsies to see whether or not their findings will correlate with outcomes.
It's important to note that many of these assays are really just prognostic rather than predictive. So as we've said before, just to review, prognostic means that, it can be a sign of the aggressiveness of the cancer and how likely it is to come back in the future. Whereas predictive means that it is actually showing that there's benefit to using chemotherapy.
So because it's the most commonly used and, as we'll get to, has the best prospective randomized controlled data, Oncotype is what we're going to spend most of our time talking about for now. The Oncotype was validated utilizing the NSABP B20 trial. This is a trial published in 1988 that was comparing tamoxifen and chemotherapy at that time, which was CMF versus tamoxifen alone in node-negative breast cancer. This was a study of 2,300 patients. There was 670 of these patients had available biopsy samples, and it was found that higher Oncotype score, which ranged anywhere from, in theory, 0 to 100, predicted a better effect on chemotherapy. Scores greater than 31, showing a significant benefit on DFS and OS in patients with a recurrence score greater than 31, and in those patients with a score less than 18, showing no clear benefit. This did have a lot of uncertainty for those patients in the gray zone. However, some follow-up analysis did find that there seemed to be at least a disease-free survival benefit consistently shown in those with a recurrence score greater than 25, which was helpful, but keep in mind this is still similar to observational data where it was a non-pre-specified outcome and we only had 670 samples available from the 2,300 patients. So some limitations, but was a promising tool. And quickly, for patients with a score greater than 25, were considered to be likely to benefit from chemotherapy in these node-negative patients.
So that brings us to the landmark TailorRx trial, which was the first prospective trial to validate the Oncotype score in node-negative patients. And this reported a 9-year follow-up in 2018 in the New England Journal. The study looked at almost 10,000 patients, 9,700 patients, all with node-negative disease, all hormone positive or HER2 negative. And the main point of this study was to look at this intermediate risk group, so patients with a score of 11 to 25. In this group, there was around 6,700 patients, and they were randomized to chemotherapy or no chemotherapy. This was a non-inferiority trial, and the primary endpoint was invasive disease-free survival, which was either local recurrence, distant recurrence, second primary cancer, or death.
The majority of patients in this study did have tumors that were greater than 1 centimeter, so very few were T1A and only a few were T1B.
So at the 9-year follow-up, this was shown that omitting chemotherapy was actually non-inferior to the chemotherapy group with a hazard ratio of 1.08 and a p-value of 0.26. So at 9 years in the intermediate group, the invasive disease-free survival was 83.3% in the endocrine therapy alone group versus 84.3% in the chemotherapy plus endocrine therapy group. In addition, distant recurrence and overall survival were also non-inferior with omitting chemotherapy. Of note, there was some benefit in women under the age of 50 with a recurrence score of 16 to 25. So in this intermediate group, if you were less than 50, there was a small amount of benefit, especially if your score was 21 to 25.
And looking at the individual subgroups here, specifically looking at that medium risk group, so comparing the 16 to 20 patients and then the 21 to 25 patients using the Oncotype score, disease-free survival at 5 years, looking at patients with a score of 16 to 20 and patients who are under the age of 50. The difference of disease-free survival at 5 years was 92% versus 94.7%. And at 9 years was the difference of 80.6% versus 89.6%. There was a higher risk of invasive disease-free survival, which includes, local, contralateral, and distant recurrences. However, when we look at the overall survival difference at 9 years for patients under the age of 50 with a score of 16 to 20, overall survival is 95.8% versus 96.1%, so no significant difference. Breaking down the subgroup of the patients with a recurrence score of 21 to 25, we do see that the invasive disease-free survival of 5 years was increased with a 92.1% versus 86.3%, and at 9 years this was 85.5% versus 79%, so about 6% difference. Overall survival did appear slightly improved in the patients with this recurrence score of 21 to 25 of 94 versus 92.7%. I think it's safe to say, slight gains in this middle range for these patients under the age of 50, but there definitely does seem to be a benefit there, trending greater for patients with a recurrence score greater than 21.
Yes, I know we just spit out a lot of numbers, and sometimes it can be kind of tedious to interpret all of this data, but kind of bottom line, for patients with hormone-positive, node-negative disease, in the low-risk group, which is a recurrence score less than 10, the data has shown that there's really not much of a benefit to chemotherapy. And for patients in the high-risk group, which is a recurrence score greater than 25, these patients would benefit from chemotherapy. And for this intermediate risk group, 11 to 25, over the age of 50, it's been shown that there really hasn't been a benefit to chemotherapy, but you would consider it for patients under the age of 50, especially in this if the recurrence score is 21 to 25. That's really where we saw much of the benefit. There is some thought that the reason why these younger patients had a survival benefit and a disease-free survival benefit with chemotherapy is that not really just the actual chemotherapy itself, but the fact that these women had ovarian suppression from the chemotherapy. These women under 50 were mainly premenopausal. As we know, chemotherapy can cause ovarian suppression, so there's thought that this was just from ovarian suppression rather than actual chemotoxicity from the chemotherapy.
Yeah, I find the Oncotype report pretty helpful. If you have a patient who is considering chemotherapy and they have this sort of intermediate appearing tumor, T1C, T2A, the nice thing with the score is you can send it, you get a score back, and you can give a general estimate of the absolute disease-free survival benefit as well as approximate some overall survival benefit and be able to present that to your patient. I think it's important to be upfront with your patient with what the goal of this Oncotype score is, because you are, as Those of you who have treated breast cancer know that the choice whether or not to pursue chemotherapy is a very personalized one. You'll come across patients who say absolutely no, there's no way I would ever do chemotherapy. And for those patients, I'm not sure there'd be a huge benefit of sending an oncotype. You really want to send if it's going to help them make a decision, because it does take about 4 weeks to come back, and that can delay other potential treatment and add undue stress for someone who's going to ultimately say no to chemotherapy, even if the score is in this 40 to 50 range. I think it's also important to be mindful that, as with all these next generation sequencing, essentially your sample that you're sending off is a portion of the total tumor, so there are some limitations here. And if you have a very well differentiated T1A tumor, I don't think that there's a huge benefit of sending this test because it's not well represented in these studies. And even if you were to get a very high recurrence score from a T1A or even a well differentiated T1B, I think the bigger question is this truly a very bad tumor, or is it just a inconsistency from your oncotype? There is one other prospective study that's worth mentioning, and that's the MINDACT trial, which is looking at the mammoprint score. This was a study that was similar in style to the TailorRx by taking clinically intermediate tumors and seeing whether or not the score is able to predict outcomes. A bit different than the TailorRx, the study did include some node-positive patients with N1, so 1 to 3 lymph nodes being positive. And this used a score that gives either a high risk or low risk, so not a numerical number such as our oncotype. And they, in this study, took patients and first off assessed their clinical risk using one of these clinical risk scores that we've been using previously. And then ran a mammoprint on it. For patients with a high clinical risk and a high genetic risk, these were recommended for chemotherapy. For low clinical risk and low genetic risk, these are recommended for just hormone therapy alone. And in the patients with discordant scores, they were then randomized to chemotherapy versus no chemotherapy. And the primary analysis of the MINDACT trial was looking at those patients with a high clinical risk and a low genomic risk to see if the mammoprint score was able to predict a lack of need for chemotherapy. They did find at the time of their analysis with a 3-year follow-up that the median disease-free survival was 96.3% versus 95.6%, which was an insignificant difference between chemotherapy and hormone therapy alone, showing that with a low genomic risk, you can likely omit chemotherapy in these high clinical risk patients. And there's not really a whole lot of data on menopausal status. And they had also called patients with micrometastatic lymph node involvement, so N1-MI, as node positive. So it's unclear how many of these node positive diseases are truly node positive or N1-MI. And I don't know if we've mentioned this previously, but in general, we consider micrometastatic lymph node involvement to be a lymph node negative disease from a clinical risk score.
So now that we've talked about node-negative disease, there was a similar trial looking at this in node-positive disease, looking at patients with 1 to 3 positive nodes, so whether or not they benefit from chemotherapy in addition to endocrine therapy. This was addressed in the RxPonder trial, which was a pretty recent trial that was published in 2021 in the New England Journal of Medicine. This trial included patients with hormone-positive, HER2-negative disease, and patients with 1 to 3 positive axillary lymph nodes. Patients with a risk score of less than or equal to 25 were randomized to endocrine therapy alone or chemotherapy in addition to endocrine therapy, and the primary outcome was invasive disease-free survival. This study included about 5,000 patients and included both premenopausal and postmenopausal patients.
About 1/3 were premenopausal.
And at the most recent follow-up, which was at 5 years, the 5-year invasive disease-free survival for the postmenopausal patients was not significant. With endocrine therapy, it was 91.9%, chemotherapy 91.3%, so there was really no benefit for chemotherapy in these patients, hazard ratio of 1.02. Now looking at the premenopausal patients, there was a small difference with 5-year invasive disease-free survival of 89% in the endocrine therapy alone group and 93.9% in the chemotherapy group with a hazard ratio of 0.6. There's also a improvement in distant relapse-free survival in the premenopausal group with a hazard ratio of 0.58. as well as a small overall survival benefit. 5-year overall survival of 98.6% versus 97.3%. Just some things to note, the chemotherapy that was used in this trial, about half patients got anthracyclines, the other half got docetaxel and cyclophosphamide. And it was a fairly low-risk population. Only 9% of the patients actually had 3 nodes involved, and only 10% of the patients on the trial had grade 3 disease.
So I think this is a pretty exciting trial with the concept that prior to this, there really were no trials that would consider omitting chemotherapy in node-positive disease. I think in postmenopausal patients without any high-risk features, N1 with 1 or 2 nodes involved, maybe 3 nodes if they don't have any other high-risk features, you can consider using the score to omit chemotherapy, if their score is less than or equal to 25. Personally, I have a hard time considering omitting chemotherapy in a node-positive premenopausal patient. I think there is an argument, as the study was enrolling after the soft text had published, whether or not we could achieve similar benefits with ovarian suppression in these lower-risk patients. I think this would still be an experimental idea, and although maybe other providers would think differently, if I have a node-positive patient who's premenopausal, I would still recommend chemotherapy, given that there was a significantly increased invasive disease-free survival and a slight trend towards improved overall survival in that population. I don't know if you feel differently.
Yeah, that's a good point. I kind of feel the same. I think it would be kind of a tough argument to omit chemotherapy, especially in a young patient.
So certainly tools with clinical utility, and we're continuing to find more use of them as trials come out. Depending on the healthcare system you work within, you may be limited to what insurance will cover or what is locally available. So it's worthwhile to be aware of the more intricate details of these other recurrence scores, at least to be kind of aware that they exist and where you get the literature on them if you need to use them. So the other thing we wanted to discuss today is the role of CDK4/6 inhibitors, and this is certainly a hot topic in early breast cancer. As with the recurrence score, we're going to be talking about patients with hormone-positive disease, HER2-negative disease. So patients with HER2-positive disease will be saving for later discussions. We're going to go a little bit more detail in these agents when we discuss metastatic disease, where they have certainly more of an established role at this point. But just briefly, the CDK4/6 inhibitors are targeted agents developed given the fact that in metastatic breast cancer it was found that hormone-positive disease had an upregulation of the cyclin D1, which is, you remember back to medical school days or in your oncology training days, is involved with the cell cycle. Although this is difficult to discuss over this format, I do recommend you looking at a figure just to see how these agents work. That is definitely a high-yield topic depending on where you're training. Cyclin D1 in general works upon phosphorylating the RB protein. When the RB protein is phosphorylated, it's unlinked from the protein called E2F, which leads to gene proliferation. So as there's an increase of cyclin D, there's an increased activity of E2F and increased cell growth and division and hormone-positive disease. This is downstream from the estrogen receptor and works in a different way. So targeting this provides a second way of attacking these breast cancer cells, and the CDK4/6 inhibitors essentially inhibit cyclin D1 and allow for ongoing gene suppression. There are 3 FDA-approved agents: palbociclib, abemaciclib, and ribociclib. These are Me-Too drugs, which means that in general they are almost identical molecules. They've been developed by different drug groups and all have their own individual trials and slightly different side effect profiles. But I think as far as functionality, and this has been shown in the metastatic setting, these are fairly equivalent in how they work. And there's some good FDA meta-analyses, which we'll get to later, showing that they are likely equivalent in efficacy in the metastatic setting.
Although there have been no head-to-head trials comparing them directly, which is an important point.
And there's unlikely to ever be. In the adjuvant setting, 2 of these agents have so far reported out clinical trials, one for palbociclib, which was a negative trial, and one for abemaciclib, which was a positive trial.
So looking at palbociclib, this was studied in the PALLAS study, which looked at 2 years of adjuvant palbociclib after surgery and chemotherapy if indicated. The study was published in February of 2021. So fairly recent, and it was a phase 3 trial of about 5,700 patients. The patients in the study were either stage 2 or stage 3, all hormone positive, HER2 negative. About 82% were either stage 2B or stage 3. 18% were stage 2A. 82% of the patients in the study did receive chemotherapy. The groups were stratified by whether or not patients received chemo. 59% of patients were considered high clinical risk, so either having 4 lymph nodes positive or 1 to 3 lymph nodes positive with either T3 or T4 disease, so a tumor greater than 5 centimeters, or grade 3 disease. They use the same dosing for palbociclib that's used in the metastatic setting, 125 milligrams daily for days 1 to 21, so 3 weeks on, and then a 7-day off period. And the primary outcome was invasive disease-free survival.
This was powered for a hazard ratio of 0.75, which would assume an absolute risk reduction of invasive disease-free survival about 3%.
So at median follow-up of 23.7 months, they found no difference in invasive disease-free survival in the palbociclib group versus the group that did not receive palbociclib. So in the palbociclib group, the 3-year invasive disease-free survival was 88.2% versus 88.5% in the endocrine therapy alone group. The distant recurrence-free survival was also the same. At 3 years, it was 89.3% in the palbociclib group versus 90.7% in the endocrine therapy alone group. The overall survival in the study was immature, so they could not report on that. However, the study was closed for futility.
Yeah, I think it's good to be aware that when clinical trials are started, there's pre-planned analyses, usually done at preset times or after a certain number of events, at which time, investigators who are separate from those, the treating clinicians, get to look at the data. And if they see an extremely significant increase of benefit, the study might be stopped early in order to ensure that the control group get a significantly better therapy. Or if there's absolutely no benefit being shown, assessed with a statistical analysis, to not continue giving patients futile toxic medications, which is what happened here.
In terms of toxicities, the adverse events that were reported are similar to what we see in the metastatic setting, and we'll speak about this when we get to that talk. But the main things are neutropenia, leukopenia, and fatigue. Even though there was a significant amount of neutropenia, neutropenic fever was actually not very common. And 42% of patients did discontinue treatment early, with half of those being because of adverse events, which the investigators think could have contributed to why this was a negative study.
Yeah, this was an open label trial, so the investigators, so this was not placebo controlled. The investigators did mention that sometimes the dose reductions or discontinuation were not in line with the clinical trial pre-specified recommendations, especially given that it's fairly well known that palbociclib, some mild neutropenia, does not predispose one to an increased infection. So another limitation in the study were that the total events were less than what would have been predicted based upon historical trials. So patients had a much greater disease-free survival than has been seen historically. As Ryan mentioned, the 3-year disease-free survival in these stage 2 and stage 3 patients was 88%. And it's thought that this is likely as a result of improved radiation, chemotherapy, and surgical techniques as well. As patients had done a lot better, they really needed to have a larger benefit than they initially predicted to be able to show statistical significance for palbociclib.
This brings back memories of the IDEA trial when we spoke about that the patients ended up doing much better than the investigators initially thought.
Yeah, all these great advances in management of cancer are making it harder and harder to run clinical trials to show benefit.
Good problem to have, I guess.
Interestingly, another trial looking at similar medication but slightly different inclusion criteria was positive, and this is the MONARCH-E trial looking at abemaciclib. So this was also an open-label trial looking at 2 years of a CDK4/6 inhibitor, in this case abemaciclib, added to endocrine therapy after chemotherapy if investigators deemed it required. The difference in the study was limited to high-risk patients, so those with greater or equal to 4 lymph nodes, or patients with 1 to 3 lymph nodes, with one of the 3, a tumor that was greater than or equal to 5 centimeters, a grade 3 tumor, or Ki-67 that was greater than or equal to 20%. The primary outcome for the study was invasive disease-free survival, so similar to the PALLAS trial. It was powered for 85% to show a hazard ratio of 0.73, in this case assuming a 5-year invasive disease-free survival of 82.5%. There's 5,637 patients with a median follow-up of 15 months, randomized 1-to-1. 60% of these patients were greater than or equal to 4 lymph nodes. 95% of these patients had received chemotherapy prior. 70% had been receiving an AI. 40% were premenopausal. There's a small population receiving ovarian suppression and AI there. The 2-year invasive disease-free survival at the initial publication did show an improvement with 92.2% versus 88.7%, which has a ratio of 0.75, was statistically significant. Furthermore, looking at specifically distant disease-free survival, this was improved at 93.6% versus 90.3%. Toxicities of abemaciclib are a bit different than palbociclib, and primarily in the order of diarrhea, with 80% of the patients having some grade of diarrhea and 8% of them having grade 3 or greater diarrhea. There's also a slightly increased risk of VTEs, so DVTs or PEs, of 2.3 versus 0.5%.
So they recently reported the 3-year follow-up. So 3-year invasive disease-free survival was 89% in the abemaciclib group versus 83% in the control group, with a hazard ratio of 0.47, absolute improvement of 5.4%. There was also an improvement in the distant relapse-free survival at 3 years, 90% in the abemaciclib versus 86%, with absolute improvement of about 4% and a hazard ratio of 0.69. So far, there has not been shown to be an overall survival benefit, even at 3 years. There have been few events, just given the trajectory of breast cancer. They did report an interesting subgroup analysis where they broke down the Ki-67. If it was greater than or equal to 20%, there was a 7.1% absolute benefit of invasive disease-free survival. And if it was less than 20%, there was a 4.5% absolute benefit. So patients benefited regardless of the Ki-67. It did seem to be a slightly greater benefit if the Ki-67 was greater than 20%. Interestingly, when the FDA approved the abemaciclib, the FDA approval was actually narrowed to patients with hormone-positive HER2-negative disease and a Ki-67 greater than or equal to 20%. So this was actually different than the trial population and different than the NCCN guidelines. It also depends, different labs can measure Ki-67 differently. In the trial, it was done by central assessment, but different local labs can do it differently. So it's also an important thing to keep in mind.
Yeah, Ki-67 is well known for having limitations in external reliability between different pathology labs. It's also not generally run by many pathology labs given this. So if you're someone who's going to be considering using this agent, you're going to have to be reaching out to your pathologist and asking for them to include that as part of their assessment if you're going to want to have insurance approval, if you're working in the United States or another country which is requiring that finding in order to have the drug approved.
It's also important to know, and I've come across this in clinic, that you want to look at the Ki-67 before, if the patient got neoadjuvant chemotherapy, which some of our patients do, you want to look at the Ki-67 before they got the neoadjuvant chemotherapy because it can change after chemotherapy if you're looking at the surgical specimen. So if it was 20% before they got the neoadjuvant, that would be what you want to look at.
So it's sort of interesting that, two trials using very similar drugs, similar design, have significantly different outcomes. Of course, the latter trial has enriched patients to have an increasing number of events. So certainly if there is a benefit, it's going to be more pronounced in that group. In theory, assuming that there's a, relative risk reduction that's going to be proportional based on the patient's risk, you would think to see that there would be a trend of improvement in the palbociclib arm, although that was not the case. Authors of the MONARCH-E trial proposed some possibilities. Of course, the higher risk they do quote as being possibly a cause. They also hint maybe the continuous dosing of the abemaciclib might be playing a role. Not so sure that it should necessarily make a difference given that they're similar in the metastatic setting. I think Ryan and I have slightly different opinions on the role of abemaciclib in the early setting. I personally have some reservations considering this medication in the adjuvant setting. I think the data is still quite immature. If we're giving abemaciclib for 2 years, we know that this is an active agent in breast cancer. And the question for me is, are we just suppressing the recurrence of these tumors? The first analysis was at 2 years, so patients were still completing the drug. Analysis at 3 years is only 1 year out, so certainly not that long later. Why that matters to me is that I think the goal of adjuvant therapy should be increasing cure. And if we're just delaying recurrence, and then we have recurrence, and now we have disease that may be selected to be resistant to our CDK4/6 inhibitors, we may have limited benefit in the metastatic setting. And I'm personally waiting for some longer follow-up and overall survival data before recommending it myself.
I think I would probably have a discussion with the patient about this. There is a 5% improvement in invasive disease-free survival at 3 years. Again, we don't have any overall survival benefits, so I'm curious to see what that shows. But, given that we do have this data, I think it's something worth considering.
So bottom lines, in our patients who are low risk, so either node negative or a postmenopausal woman with 1 to 3 lymph nodes, and it's a patient who would be interested in chemotherapy if there's an indication for it, consider using one of your clinical risk tools. These have helped show and select patients more accurately than our historical clinical risk calculators for those who are going to be more likely to benefit from chemotherapy. I think it's important to remain mindful of the classical clinical risk tools, making use of the NHS Predict, as these will still help put things into context and make sure that you're not going to have a recurrence score that's completely out of proportion to what the general risk might have been.
And for your high-risk patients, so stage 2 or stage 3, or high-risk features such as grade 3, greater than 5 centimeters, or Ki-67 greater than 20%, you can consider the addition of abemaciclib for 2 years, in addition to endocrine therapy based on the MONARCH-E study, which again has not reported overall survival yet, but does have a small improvement in invasive disease-free survival.
We hope this was a helpful overview on this emerging area in early breast cancer, and I'll look forward to continuing the discussion of CDK4/6 inhibitors as well as our SERDs such as fulvestrant as we move into the metastatic hormone-positive space next time.
Thanks for listening, and again, please feel free to email us or message us on Twitter if you have any feedback, and good luck with the match.
Bye for now.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.